Well, welcome everyone who was able to come today to the Sustainable Healthcare Cost Growth Committee. I think we have some debriefs and some updates on the agenda. I think in your packets, you have an updated charter in the meeting packet for today. And is Jessica on, Sarah? I'm having a hard time scrolling through the list of people.
I am on.
Oh, great. Thanks, Jessica. Welcome to the meeting. Do you want to take a moment to introduce yourself? Maybe if you could say your name, where you work, and if you have a pet and what their name is.
That makes it easy. So Jessica Richard, I work at Cambia Health. You might know them as Regents Blue Cross and Shield of Oregon. I work in their finance area. I have been in the healthcare industry for about 20 years now, and I've worked on both the insurance side, the provider and hospital side. I've worked in rural and urban, and my pet, I have a dog who I think runs the household. So I'm very happy to be a part of this and having this important discussion. So thank you for including me.
Great. Thank you for joining our group, and we're very excited to have you. And then I think I'm going to go through committee members and have you introduce yourselves so Jessica knows who you are. And this is going to be a tough way to do this. So let's start. Okay, let's start with Jim. Jim, you want to introduce yourself?
Thanks, Felisa. Good morning. My name is Jim Hauser, retired auto shop owner at Hawthorne Auto Clinic and chair of the Main Street Alliance of Oregon. Thank you.
Great. Peter?
Well, good morning. Jessica, I'm Peter Davidson. I'm the CFO of Pacific Source, and I get to co-chair this meeting with Felisa.
Nick?
Good morning. I am the CEO of Winding Waters Clinic, which is a rural or beyond rural FQHC out in Wallowa County.
Great. Mary Beth?
Here we go. Sorry, having trouble unmuting. I'm Mary Beth Garino. I am the healthcare advocate at Osberg.
Great. Sarah, can you help me out? I'm like really.
Yeah, no worries. Let me go down the list. I think we have Katie.
There we go.
Oh, here I am. I'm Katie Koenig with Oregon Business and Industry. I'm the public affairs manager and happy to be here. I'm going to keep my camera off. My allergies are out of control and I'm going to spare you from watching my sneezing fits.
It's a tough season.
Lawrence is on, but stepping away. So maybe we come back to him later.
Great.
Melissa.
Sorry, I'm a new, I'm not at home. I'm on vacation right now and just hooking up on a new internet. So I'm Melissa Dom. I'm the CFO for Providence in Oregon.
Great. Who else do we have?
That's everyone I'm seeing, but I'm also scrolling. So if I missed anybody, apologies.
Yeah. Michelle? No. Doug, why don't you introduce yourself? You're going to give a presentation later, so.
All right. Hi, I'm Doug Boyson. I work for Samaritan Health Services based in Corvallis, Oregon.
Great. And Bill?
Are you asking me, Felisa?
I am. Thanks, Bill.
Bill Kramer. I'm not a member of the advisory committee, but I'm a member of the Oregon Health Policy Board. and I'm the liaison to the Cost Growth Target Advisory Committee.
Okay. And then I think we have a lot of staff on who are going to help, who are constantly helpful in this process and will continue to be helpful throughout the process. And I, as always, want to encourage folks if they have questions or don't understand something or there's an acronym. I know, Jessica, you're new to the committee, but you've worked in healthcare for 20 years, so you probably know more acronyms than all of us put together. If you want to put that into the chat or ask questions of staff, please do that so that we have everybody on the same page as we are moving forward. I think the next, and then staff, if you're giving a presentation or jumping on, it would be really helpful if you would introduce yourself a little bit before the presentation and say what you do in plain language English for the Oregon Health Authority, so that everyone's up to speed. So I don't think we can, Gerardi, if you want to, we can start the slides. Okay, so we've done our welcomes, I think. So I think this is the agenda for today. If people have had a chance to review it, are there, and I cannot see, hold on just a second. There we go. If there are any thoughts or comments on the agenda, I want to remind people, as always, if we could just do me a favor, this is a little bit hard to see. If people could use the raise their hand function under reactions, which is at the bottom of your screen, you'll see a little smiley face with a plus sign above it and an arrow next to it. And that way, when you push that up, you can see a raise your hand function there. And so that you pop to the top and we can actually get you, just because I can't see everybody who is all of your little boxes, which is great because we have so many folks here participating. Any thoughts or questions on the agenda? If not, I'm going to move us forward. Okay, great. So I think that the things we want to go through today is we want to talk about the public hearing that we had and debrief the May hearing. We're going to move through the September planning and get into talking about some of the program updates. So let's just kick it off with debriefing the public hearing and start planning for the September hearing. So if we could actually stop the slide share so I could see more boxes, that would be awesome. Okay. So I'm just going to give this opportunity, I think, just to do a quick reminder. It was May and we've all slept since then. So we had our first round of data come out pre-public hearing. That data was the first time that we reported the trend for individual systems, both on the insurance side and the provider side. And then we had a public hearing to sort of discuss those. That was a combination of presentations and panels, as well as sort of reviewing that overall data and hearing from some consumers. So as we think back to the public hearing, we want to start with some basic questions. What do we think worked well during the public hearing? What do we think was successful? Sarah, I'm also going to open this up. I know that the staff have probably done many debriefs of the public hearing, but we have only a handful of board members here today. And so I want to make sure that everybody can participate just so we can get more voices into the room. So Mary Beth?
Yeah, I was just going to say, I think that the consumer stories were really powerful. I know that someone from Josefina and Michelle, I think their names were both really, I think, effective at showing why we're here and the purpose of the cost growth target to reduce costs so that folks like them don't experience the struggles that they're experiencing. So I think it was just a really powerful level setter for the conversations that we'll have later this year in the second hearing as well.
And other thoughts about what went well?
It
Oh,
was my,
Jessica.
sorry, I forgot the hand raise. I think
No,
Peter
it's
was
okay,
next.
great.
So I thought it was really great to hear from Providence where they had both the payer and the provider side of it. It made me think about, you know, what our role should be in addressing the public, and I really appreciated that. And I will agree, having the community members hearing their voice, I think, is a good reminder to all of us the reality of the decisions we're making and the work we do. So I think having those stories was really impactful.
Melissa, you were on a panel and at the public hearing. Do you have thoughts?
Yeah, I thought it was a good dialogue. You know, it is really good for everyone to hear kind of what our consumers, you know, or what our patients and what our communities faced with. You know, personally, I hear those patient stories and I just want to problem solve for them, right? You know, when you understand what goes on and, you know, kind of the dynamic. So it speaks a little bit to how complicated navigating our healthcare system is, and the challenges with that on the payment side. So I walked away a lot thinking about the community members that, you know, how challenging it is for people to navigate between their insurance, between a health system, between a provider. And that always strikes me when you hear those stories, and how it really, you know, makes it more challenging to get well when you're stressed out about those other things.
Yeah, definitely. Other folks, Jim or Bill, Peter, Katie? I see a clapping emoji from Peter.
Apologize, don't understand all the emojis.
That's okay. Okay.
So, you know, Melissa, I think you're absolutely right. I think that the consumer stories are incredibly important, and the work we do is just one component of being able to solve the myriad of issues that create barriers for people to get health care. You know, what I took away, Felisa, from this meeting is that we have a really strong, very high quality base benchmark to start our work. I thought the reports from OHA were excellent. And I think, or hopefully, you know, I took away, and maybe the public did, that we have a quality process to start this work and to build off that. And then I think the consumer stories, as I mentioned, just point out how much work we have to do, not only in this committee, but across the state.
Bill?
I was going to say much of what Peter just said, so I'll echo that. I think keeping the consumer stories, the situation that consumers and patients face, as well as what employers face, is really forefront of this. That's the basis on which the targets were set. And in looking at cost drivers and other issues, we just need to remind ourselves that what we're trying to do is solve a problem for the people of Oregon. And so that if we keep that in front of us at every meeting, in particular in these public hearings, I think that'll be very important.
You know, I think one of the things I just want to jump in, I feel like when I was looking at the report, as well as when I was listening to the panel and the consumers, my takeaway was that this is a process that people are taking seriously. And they're really, I feel like, digging in and leaning into trying to solve and commit to solving these challenges on the provider and the payer side, which I appreciated. You know, I think we only had a few people who were outliers, and we only had one data submission problem in a incredibly diverse insurance market, right? One of the most diverse insurance markets in the country. And I think that should be applauded, that that people are taking this seriously. I also, one of my key takeaways, I think very similar to Melissa's takeaway on the consumer front, is that patients aren't going to be able to solve this, frankly. They're part of knowing and identifying the problems, but we've created a system so complex that your ability to navigate it, like Melissa said, when you're well, is pretty difficult, right? When you're feeling great, when you're feeling poorly, and when you're feeling really poorly and your costs start to mount, your ability to navigate the programs and the complexity and the sort of institutions on your own, you just don't have that. And most very high functioning people don't have that. And so when you're not at your most high functioning, there's no way you would be able to do that. So I think as we think about the sort of systemic change that we're trying to create here and being one piece of the broader puzzle, I thought the consumers did a really good job of sort of grounding that for us. As well as I thought the both Pacific Source and Providence participating in the panel to talk about their experiences, the challenges that they face, how they're thinking about it, I thought was very insightful. So I appreciate everybody who stepped out to do that. And it was the first one. So kudos to you for being the first ones. Are there other takeaways from the public hearing in May? Before I'm gonna jump us into September planning. I also do want to give the staff. Oh, Nick.
Thank you. Navigating the emojis too. I do think I'll just repeat a piece of what you said, that it's really important to acknowledge the level of complexity and that this takes time, has already taken multiple years from the first group, and will take more time, but that working through a process and pulling out the pieces will help us manage that complexity and get to a good outcome, because the patient stories and hearing from payers and hearing hopefully more from providers as well, it's extremely complex. We all want what's best, and trying to define that is very hard. There's no one answer, so we need this process in order to tease out the complexities and get to a good answer.
Other sort of reflections on the May hearing before I move on to September.
Lisa, I think I see Michael Baylett on the call, and Michael works with cost growth target states across the country, several of whom have also been having public hearings. So I'm wondering if he has any reflections for us to put him on the spot.
Yeah, that would be great, Michael.
Oh, got the on camera on.
Oh, there you go. Boom. Yay.
Hi. Hello, everyone. I know some of you, but not all. So public hearings are a relatively new thing for states with cost growth targets. You guys just did your first. Connecticut just did their first. Some other states have been having public forums, but a public forum isn't quite the same as a hearing. I think that the challenge for the states is multifold with these. I think what you did by bringing the patient voice first is important, and is something that other states have tried to do, because it really centers the work and reminds everyone of really the moral imperative of the work. The next part, which is sort of exploring why is healthcare spending growing at a fast rate and what to do about it. I think that's the challenge for states, to figure out how to use the hearing as a positive force to advance improved affordability. And I guess Felisa, this is a good lead into your next topic, your September agenda, right? Because it's to think about how to do that, and how to make it constructive, and I would say how to use it as a vehicle for making forward progress, and not just promoting a lot of finger pointing. because I think there's a risk.
That's very good feedback. And of course, Michael, we want to ask you the question. If you were to rank the states as the best to the worst, where did our public hearing fall on that list?
Well, so I have an easy opt-out. I wasn't able to participate. So all I know is what I'm hearing you guys talk about today. So I get it. But frankly, there haven't been that many, Felisa. I mean, this is really, it's a very small number of states that are doing them. And only Massachusetts has been doing them for a long time.
I think Michael's comments really does set us up for our next sort of planning our September hearing. And I think that I think the other component of this, as Michael said, is these hearings are new. And there is no perfect way to do them. And there will never be a perfect way where we have the perfect hearing and we magically solve the problems of healthcare costs. So we should not be planning or looking for that silver bullet. But I think what we should be thinking about in our September hearing is some of our takeaways from the May hearing and also some of the questions that we asked previously around what do we want to get out of these? So what are we looking for to hear from the public? And I want to be very clear about when we say the public, because, you know, oftentimes when people think of the public, we think of broadly like everyone. It's not true. We're also never going to have a public hearing where we really hear from everyone and we don't hear from people who are highly engaged. So I think the proposed agenda for the September hearing is on, Gerondi, can you pop up slide 6? And I want to apologize to Gerondi. I'm like bouncing around and not letting them go through the slides in order. They're like, this woman is ruining me. I'm sorry. Okay, so I think we'll have our welcome and opening remarks, a presentation on the key cost drivers. Panel 1 is commercial payers. Panel 2 would be large provider organization. We'd take a break. Number 3, we'd have public payers. And number 4, we'd have small provider organizations. And then wrap that up with public comment. I think that there's a couple of things that I want to ask folks in this. I think this is the hearing where we're going to get down to some of the sort of the nitty gritty about how people are making the target, what are the challenges to the target, what are they instituting or implementing that they think can help get them to sort of help get them to a path or maintain being on target. And really setting us up for sort of a long-term thinking about really specific strategies. And I think as Michael outlined a little bit is how do we do that in a way that is not a bunch of finger pointing, which I think is tough, right? I think that there's a lot of components that go into the target. And so I think the default often can be, it's not me, it's somebody else, which is true of every problem. I mean, I woke up this morning and I was like, this house is a mess. Who did this? And then I was like, oh, I live alone. So I feel like I think that's sort of where we want to get to. Are there thoughts? I want to talk about this agenda and ask sort of, are there any sort of overall thoughts on the agenda, first of all? When we look at the report, are there sort of specific payers or provider organizations that we really want to recruit to be a part of this? And are there specific questions that we want answered? What are the outcomes we're trying to get to? Melissa.
Yeah, one of the things I think again about the community members on that spoke last time is and we've talked about this as we look at the data and we focus on allowable. I think a piece that's missing and that they're speaking to is kind of what that out of pocket is. And, the challenges on those high deductible plans. And so I just wonder, the public hearing is not the place for this, to really understand kind of where Oregon lies on those kind of percent of high deductible plans. But then maybe some comments from commercial payers around what they're hearing from employers, you know, and the challenges that they're facing, I guess, because the patient and the navigation through the system is one thing, and you know how they pay, and we've got great financial assistance access right in the state through a lot of the advocacy, but it's not kind of hitting on the pocketbook of a lot of our community. And so I wonder on the commercial side in particular, you know, some comments or context around employers and what, you know, how those conversations are going or how they make those decisions. I don't know, or how they've seen that, how we've seen that change. And I honestly don't know how this state compares to other states with kind of the percent of high deductible plans. From what I see in other parts of our organization, it does look different in other states. So that just might be something, and maybe it's kind of longer term, but the data we don't have that information through what we're collecting because it's just focused on that allowable. And I think there's a gap there in us really understanding what we're hearing from our community and the challenges around cost, and what they're paying. And, you know, it would be helpful, I think, on the commercial side to understand that a little bit better in their conversations.
Great. Sarah or Andrew, I also want to give you an opportunity to jump in here and talk about high deductible plans.
Yeah,
and how we could talk about that September. Go ahead.
I'm jumping ahead to program updates, but one of the things we want to share with you is that our team is working on an analysis of patient paid costs. So we are looking at how much patients are paying as sort of a portion of the total spend, how our out-of-pocket costs shifting over time. I don't know that we'll have that in time and ready for publication in September, but that is something that we're working towards hopefully later this fall.
Great. Andrew, and then I'm going to go Peter.
Thank you, and good morning, everyone. Sorry, I was a few minutes late. So to answer your question, a couple of general.
Oh, sorry,
different
Andrew. I realized. No, you, Andrew, you. But can you start with where you work and who you are? I guess Jessica from Regents probably knows you, but go ahead.
Absolutely, thank you. Apologies for not doing that to start. So I'm Andrew Stolfi. I use he, him pronouns. I'm the DCBS director and the state insurance commissioner. And very glad to be here again with the group. So you asked a couple of general questions. So about so a couple thoughts, and then happy to answer other specific questions. But around payers and carriers and the kind of what mix of what types of folks to get. Well, maybe just to step back a second. So DCBS, we do organize a lot of kind of public hearings similar to what we're talking about here. We do annual rate review hearings on the rates that carriers submit for the individual and small group market. And we've been doing those for a long time, since the ACA market came in. And I'll tell you, when we first started doing those, they were very well attended, robust hearings with lots of discussion and debate. And as the market got more and more settled, we get barely anyone attending those meetings. We also do other types of annual hearings or discussions, like on prescription drug pricing, and those are very well attended. And there's a lot of robust discussion. So some definitely lessons we learned from that we can maybe use. So I'd say around the payers and like who to include, just to keep in mind, like there's two general types of ones. We'd want perspectives from both, like the Kaiser Providence, consolidated system type of payer, as well as more of the traditional insurer like Moda, Pacific Source, Cambia, because they do have different perspectives and views that are both very important. As far as soliciting, getting good consumer feedback, what we found is sending out surveys and requests, like let's send out requests for questions and feedback and information in advance. It's a great way to get then questions and information or ideas for presentations or topics for the hearings. You have to do that well in advance. And of course, then working really closely with all the community partners and other stakeholders to have them amplify the message, find people, and get people to attend. So that, I think again, sorry I came in a little late, but I think those are some of your kind of general questions. Happy to answer other specific ones.
I think that that's a really great component. And I think, Sarah, I feel like you and Andrew, it would be great if we could work together to think about a couple surveys we have had a hard time recruiting and engaging employers. And I know Morgan is not on this today, but with the business.
We have Katie.
Yeah.
Oh, Katie, there you are, Katie, great.
And I will just echo that. We have a really hard time getting employers engaged in this conversation, and it is frustrating because they need to be. And we have to be really intentional about reaching out to them. Doing surveys, I found with the business community, they don't respond to that, but intentional communication, they do respond to, if that's at all helpful.
I think that that's really helpful in this discussion of what we want to get out and how we want to hear from, and this high deductible plan. So I think how we think about putting a plan together around that. Jessica.
Yeah, thank you. So I like a lot of the stuff that folks are talking about here, and I agree with it. I think there's a lot of news articles that get out there. I don't know how much consumers or others read those about the cost of care or supply chain issues, nursing costs. A lot of hospitals or providers have made the news around financials, payers as well. We've had some major payers talk about how they expect healthcare costs to rise next year. So it might be an opportunity for us to talk about that. Beyond high deductible plans, I thought it also might be a great place for us to talk about clinical programs we put in place and why. And then as we do talk about what are employers saying, what are we hearing, how much the patient pays. I think that's a really great place for payers to get involved. We're in that space all of the time. And, obviously I would love to be a part of that conversation if it makes sense for me or my company to do that, but support it any way we can. But I also think people hear from payers all of the time, so it'd be nice to have join our panel way to talk about that, to make sure it's not just in insurance speak. But I think there's more than the high deductible plans. I think we'd want to talk about quality and some of the clinical programs and some of those that are available to folks to live their best and healthiest lives, not just when they get sick and have to interact with the healthcare space.
Great. Bill?
I think this is going to be a great opportunity to hear from providers and payers at this hearing. I think somebody mentioned earlier, and I want to just expand on, I think this is an opportunity to showcase some of the great things that providers and payers have done to make progress on costs, where they've had a success, particularly in improving quality and reducing costs at the same time. I know there's some great examples of that. And that could help us develop a roadmap as a state, but also to share that information among providers about the successes that they've seen, so that we can build on those successes going forward.
Great. Nick?
Thank you. I really appreciate this discussion, and it gets at the mention of providers I added earlier. I also know that small provider organizations are also small employers and have to juggle the costs of the group health insurance. And we see it on both sides, the sort of the cost of the care we're providing, and then the cost that it takes to insure our own workforce. And I think there could be some really interesting discussion around that, if that would be helpful to this group.
Great. Peter?
Yeah, thank you. I really appreciate the discussion this morning. I really like the concept of having employers maybe represent some of the challenges that they're seeing within the system. And I appreciate, Katie, that may be hard to find, but I bet there's some employers out there willing to talk about the struggles of insuring their folks. I think it's very important for us as a committee to keep a focus on not trying to boil the ocean, but figuring out what our part is in being able to move the state forward in creating sustainable targets. And that's in lowering the overall cost. And so as we get into the preamble for this meeting, I think it'd be really great to kind of reference some of what Michael talked about, what Melissa talked about, in the fact that what we're really trying to do is not point fingers at specific timeframes, but create information about what's going on, why it's going on, and how we change it, and how we change it in a sustainable way over a really long period of time. We're coming out of an environment of post-COVID with deferred utilization, with some really new high cell and gene therapy costs, with some supply and staffing issues. And it provides an opportunity to both point fingers and to create explanations. And I'm not sure either of those really drive forward the solutions. So as we set the tone for these meetings, how do we get more and more and more buy-in from plans like our own and organizations like Melissa's to really drive change? And I think that's a really important message. I do think this is a unique period of time, and we have to be a little careful about how we tread through this, especially as we talk about the accountability component that's coming up at the end, and use that again to be a lever to drive sustainable change.
Great. Ali?
Thanks, Lisa. Ali Hassoun, Interim Director of the Health Policy and Analytics Division within the Oregon Health Authority, and the Director of the Employees Benefit Board and Oregon Educators Benefit Board. And I just wanted to be happy to provide any feedback from a large employer perspective. Obviously, with OWEB, we have a couple hundred employers of various sizes around the state, and a handful of large employers. But we actually had a really robust discussion in the PEB board meeting yesterday around PEB and OWEB are under a 3.4% hard statutory cap, which is a little bit different than statewide cost growth. Even though both boards are signed up and committed to the cost growth target committee, it's a little bit different in the fact that if you have beaten the target, which PEB had this year, you're essentially resetting a baseline lower, and some of the calculations that the board was struggling with around the hard statutory cap, and looking at potential solutions to that. But I think just the experiences in general, I think we've, as both boards have been wrangling with this 3.4% cap for several years now, I think there's some pretty interesting experiences. Thank you.
Other thoughts? I'm going to do a quick summary recap where I'm sure I will miss something, and other people should feel free to jump in. So I think when we are thinking through what our September meeting engagement looks about and looking at the panels is, I feel like hearing that we want to have a diverse set of different types of providers and payers on those panels. So integrated systems, small and large providers, et cetera, so that we get a sort of a diverse set of views. I think hearing from our consumers, one of our takeaways was sort of, how do we think about how the work that we're doing impacts those sort of out-of-pocket costs and what that looks like, and those challenges in the system. And so thinking through how we use we might want to think about the payer panel, not just as an insurance panel, but potentially adding some employer panels on there. And then I think some lessons from PEB, as Ali just pointed out, about sort of its, it has had a hard 3.4% cap for a longer period of time in PEB and OEB, and both of them are large employers, and lessons learning from that. I think to Peter's point, I feel like really thinking about our opening as creating a sort of this thread of systemic change and what it means to create and drive systemic change in a system, that it is a long-term look, not a snapshot look. And that how difficult that is, but how you sort of have to keep sort of pushing forward on those components. I think Andrew had a really good point around engagement tools that I think that we need to go back and take a look at, and Katie had some specific thoughts on outreach, on that employer outreach, so we can engage and get information ahead of time before that September meeting that is more targeted. So it might not be broad-based outreach, but it could be targeted where we could hear from a handful of folks. And then I think Bill's suggestion that some of the questions and the engagement that we ask and we move through these panels is we really think about how are we learning and building from the successes that we've had, highlighting those successes, and thinking about how they can be implemented in a more systemic way. I feel like that is sort of a little bit of my summary from what we've talked about. Are there components that I'm missing that we think are really important to get into this conversation in September? Michael.
Since Sarah invited me before, I thought I'd jump in one more time.
Yes, I love it.
I think it's important to ask the question, what do we need to do differently that we're not doing today? Because oftentimes in conversations in states, I hear people describe the things they're already doing, but the things that we're already doing, generally across the country aren't working sufficiently. And so doing more of them might not be the right answer. Now, I want to grant maybe there's some things that are being newly done and we don't know, but I think asking what needs to be done differently, that is the systemic change that you were talking about, Lisa, is important. And then also having a frank conversation about and who needs to do it.
Great. I think that that's a very good. Also another segue. I don't pay Michael for these, although he's nailing it. I guess the state does, but I think that one of the really critical things that we're going to come out of the September hearing is we are then going to head into a period of accountability. And I think sort of having these public hearings, thinking about the successes, thinking about what we are going to do differently and how that looks, and not thinking about this as a snapshot in time, I think is very critical as we head into accountability. And I think all of these there needs to be a collective understanding of that, that I think is really, really important. As we head out of these public hearings. Are there other things that people want to add in, or that I was missing from that summary? Okay, well, I think that we should all look for agendas from Sarah. And Sarah had a question on here that I didn't ask, which is, what's the best way for the committee to participate in the public hearing? I just am going to assume that we are all go-getters and volunteers. And so when Sarah calls us to ask us to do something, we just say, yeah, that sounds great, Sarah. And so I'm hoping that all of us can step up to the plate and sort of be flexible and jump in when the staff need us. So as part of this process. All right. We are going to move on to Sarah and Zachary to do the cost growth target program. So I'm going to bump it over to you for program update, Sarah and Zachary.
Great.
And Ronnie, I'm sorry, you can pop back up the slides if you
And I'm gonna pinch hit for a minute here because Sarah had to jump off and present to the Prescription Drug Affordability Board. So I'll be talking about the program updates. Gerardi, can you go forward a slide, please? Great, and then one more. Great. So first I want to talk about the Cost and Equity Work Group, which has been a really fascinating and wonderful group. There have been 3 meetings thus far, and the folks have drafted some guiding principles to further kind of integrate equity into cost containment and into our efforts. And there's a link here to the draft framework. Now this is in progress. There will be another presentation in September of a kind of more refined framework, but here that's where it is right now. And then in September, we'll have kind of a deeper dive into it and solicit some input. So that work is ongoing. Let's go to the next slide, please. Let's do a quick recap of session. So session, this was kind of a very interesting session this time, a lot of unprecedented things. But most notably for us is the passage of House Bill 2045, which defines frontline worker and total compensation. It has a specific requirement to exempt costs associated with frontline worker from the cost growth target work. So it creates a requirement for providers in the program to report the aggregate amount of total compensation each year and report that to OHA, to be determined on the actual methodology and data submission and process and all those details. But importantly, it specifies that providers should not be accountable for cost growth resulting from the provider's total compensation. So that's slightly different in the sense that it just codifies something that we have been talking about here. But now that it's in statute, we'll include it in rule, and it's now statute. So we'll move forward with that. There's a link at the bottom if anyone's interested in the actual bill language. So that's the session. That's the only bill that really kind of materially impacted our program. Now, as we've said before, there are maybe some other bills that impact healthcare costs and spending, benefit mandates and things like that. And so we're for sure monitoring those. But in terms of the mechanics of our program, this is really the only one that has kind of specifically impacted our program. Let's go to the next slide. So let's talk about 23 data submissions. So that'll include costs for calendar year 21 to 22. The mandatory reporters were all notified at the end of April, a few months ago. We're talking about 19 parent organizations representing 38 plans. So a lot of plans. Data submission template and guidance were published in May on our website, and the data are due September 1st of this year. So it's coming up pretty quickly, particularly when you factor in summer vacations and whatnot. So there's a link at the bottom there to the list if anyone's interested. That's kind of the official list of folks submitting data. So that's the submission. Let's go to the next slide, and I want to talk just a minute about some really interesting things going on in other states. So Utah has created the One Utah Health Collaborative, which is a really different approach than how we're doing it, and a different approach to how other states are doing it too. It's an independent 501c3, so it's kind of private and private and public partnership. It's funded through kind of its own funding route. Very community-centric approach with an emphasis on supporting innovation. They align the community on long-term roadmap to a better healthcare system. So there's a link there. It's just kind of an interesting approach. Again, different than ours, and fascinating to watch as they develop. Secondly, Connecticut, and I think Michael mentioned this at the top, Connecticut held their cost growth target benchmark public hearing in June last month. And they had panels of drug manufacturers, which I thought was really interesting, and hospitals and insurers. So that was a really interesting approach. Overall, kind of somewhat similar to our public hearing, but different in some key ways. So I thought that was really good. Let's keep going. Let's go to the next slide. So that's it for program reports, but I want to talk a little bit about published reports that we have. Let's go to the next one. So in the past handful of months, we've published 2 reports, the 2022 annual report that shows cost growth trends from 18 to 20. And then we published the 23 annual report, which shows cost growth from 20 to 21. These were published pretty closely together. Obviously, there's a pre-COVID and post-COVID kind of dynamic here. And so that's really important to keep in mind as you read these. They each have executive summaries. So if you only have a couple minutes, I highly recommend that. And then, here at Oregon Health Authority, we love data visualization. So there's a lot of really great charts and graphs in there that hopefully summarize some really complicated points and hopefully distill it into kind of a quick graph. The link at the bottom there is to our reports page that has all our reports. So let's go to the next slide. So now I want to kind of take a little wider lens and just talk about kind of other stuff that's happening that's related and some things that we find really interesting. So there's a new health affairs article that came out somewhat recently by a member of Michael Bailitt's team, actually, from Bailitt Health. So this is looking at spending trends across the states that have implemented a cost growth target program. So Connecticut, Delaware, Massachusetts, us, and Rhode Island. And it's really interesting to see kind of the different dynamics at play. Some states have higher commercial, more than us. It's just kind of interesting, but some have less. So on the right there, per capita growth and total medical expenses by state and market. And this is in 21, so this is kind of during COVID, as it were. Most have significantly more cost growth than Oregon does, 3 out of the 5, and Rhode Island is the leader, as it were, with the least cost growth. But really interesting. It's a great report and worth your time if you have a couple minutes. Let's go to the next one. There's also a different report, and that's the primary care spend report. We do this every year, but the 21 report was really interesting. And the takeaway here is that PC, primary care spending in Oregon, has remained mostly stagnant in the past 6 years, while healthcare spending overall has ballooned. So as a percentage, it's kind of going down a bit, but the per member per month is roughly staying the same. And primary care is one of those types of spendings that should be increasing. We've talked about this a lot. We have an overall cost growth target, yet we want to see increases in some areas of spending. So primary care, it's low cost, it's preventive care. So that's really important. Another takeaway here is that there's a lot of variation across markets for primary care spending. Commercials at 12.5, yet Medicare Advantage is at 9.7. Obviously, the denominators here are very different. The risk cohorts are very different. So it's hard to really compare across these lines of business, but still interesting to see kind of how they trend. Let's go to the next one. Somewhat related to primary care, but not exclusively primary care. Oregon Health Authority also publishes payment arrangement data, which is to say, of total dollars being spent for healthcare, how many are kind of based on a fee-for-service, kind of the old traditional fee-for-service methodology, versus more of an alternative payment methodology or value-based payment. And here this is literally just a cut and paste snapshot of the dashboard. There's a link at the bottom of the slide here. But this shows kind of by carrier and by market, where in what methodology are those dollars being spent. So are they all fee-for-service, 100% in fee-for-service, or some in shared savings or shared risk, or some in population-based capitation, are some kind of with a quality pool. So this is really interesting data. It's on the Tableau dashboard, so really fun to click and poke around. And again, it's stratified by market and by payer. So it's a fun sandbox to play in. Let's go to the next one. And lastly, but not least, for sure, we had a hospital payment report that just came out somewhat recently. Again, there's a link to the dashboard. A lot of really great stuff here, just on hospitals and just on dollars going to hospitals. But we look at, for example, inpatient procedures, cumulative growth. So there's a couple, kind of the raw dollars, and then inflation adjusted, some longitudinal trends from 2017. Obviously, COVID is hitting in the middle here, so that's important to keep in mind. But then there's specific procedures. So inpatient procedures, here's a snapshot of coronary bypass and the variation in median payments by hospital. So you can show kind of the wide range of payments for a given procedure across different locations, different hospitals. Again, a really fun sandbox to play in. The data are really accessible. It's on a Tableau foundation, so you can click and kind of really draw some really great findings and conclusions. So now let's go to the next slide. Now let's talk about looking forward. These are all the reports that are out there today. In progress, we have a handful of what I think are going to be really fascinating reports and topics. So one is the impacts of healthcare costs on people in Oregon, 2021. We've done this drill before. We've done this report, but we want to refresh it, particularly in kind of a COVID, with the COVID lens. So that'll be coming out shortly. We're also going to look at pricing utilization trends, right? Cost growth, as we've talked about, a function of both of those things. So we want to tease that out of it and better understand the dynamics at play for how prices in themselves are changing and how utilization in itself is changing. We also want to do a deeper dive into behavioral health spending. We have a primary care spend dashboard, and that's great, and we've been doing that for a long time. And primary care and behavioral health have kind of been in a similar conversation in the sense that there's been active pursuit to increase spending and increase investments in both of those areas. So we want to do a deeper dive into what does behavioral health spending look like today? What has it looked like in the past? And kind of in what areas of behavioral health spending are more dollars going to? So I think that'll be really interesting. We also want to look at some patient paid amounts. This is more on the kind of consumer experience angle, right? So what does cost sharing and co-payments and deductibles look like historically and today? So I think that'll be really interesting. It's almost related to the impacts of healthcare cost growth on people in Oregon. It's related to that first one, but it's different in the sense of, this is predicated on plan design and kind of those contractual relationships between payers and providers that specify what co-payment is going to be. And then we want to look at facility fees and just better understand what the landscape of facility fees looks like. And lastly, we're looking at some relative hospital price comparisons and looking at kind of hospital prices as share of Medicare to better understand kind of the different prices across different health systems and different hospital locations. So that's what's coming up. Let me pause there before we move on to value-based payment compact update from Doug, and let me see if any folks have questions or reactions. Yeah, Melissa.
One of the things on the health affairs article, I think that, and kind of the data that's presented, it shows the other states, but it doesn't always have the context. And I think I know this happened a lot as the work group was getting together and the committee was getting formed, is the per capita spend, that we see in our state and compared to other states. I think it's both, right? It's what is the growth, and are we kind of doing better than or meeting our targets and doing better than other states on that. But then it's also kind of, you take a step back and the per capita spend and how that's getting, the per capita spend in comparison there. So there's a piece that's missing, I think, in some of that when you just compare program to program and growth. We don't also understand kind of where the per capita or the baseline is on that. The other piece I think that's helpful is just that patient mix, right? And I think we've seen this in our information as our Medicare population, as our community's aging and our Medicare population's growing, primary care is utilized more, and that may not be a bad thing. So what is kind of controllable in this really, and what is just, how healthcare is provided differently to different, generations or different ages in our community and what their needs are. So it's, as always, very complex, but I'm looking forward to seeing some of this. As you know, the behavioral health piece is just, there's so many components of that external to the healthcare system upstream. And so how we think about how we're investing to support that on the ground will be really, really important. So.
Yeah, that's great. Thank you. Mary Beth, I saw your hand.
Yeah, so for these analyses that are in progress, I know Sarah had mentioned the paid patient amounts earlier and that they probably wouldn't be ready for like the September meeting. Is there a timeline for these? Are they listed in the order that they'll be released? Do we know anything more about like that time, that like expectation of when we'll actually have the information?
Yeah, that's a great question. I don't have that at my fingertips, but we can furnish that. They're not necessarily in order, but I do know there's been a lot of work on this first one, impacts of healthcare costs on people in Oregon. So that one may be closer to the end than the others. But let me take that back and we can provide some tangible timelines so you can all have some expectations there.
He's spending the next 60 minutes or so with us, so I'm going to try to make it as informative and as fun as possible.
Oh, somebody is off mute.
To get
That
your
Scott, it looks like
let me just
we're hearing some background. Thanks. So thank you, Mary Beth. Yeah, so we'll come back with some timelines there. Felicia, take it away.
Yeah, so I just have a question, Zachary, and this actually may be a Sarah question or a Dave question. Is I think that the Health Authority and DCBS put out an incredible amount of information in public reports. But one of the questions I have is there a overarching, I feel like, is there an overarching view of the healthcare systems? Is there something that pulls all of this together to tell us where we're headed? We have a set of overarching goals and values in our state. I'm looking for sort of an overall analysis somewhere from both the Health Authority and DCBS that pulls all of this together that says, are we on track? We're not on track. And here's why, to that overarching set of values and goals in healthcare.
Yeah, I love that framing. I really would welcome Sarah's thoughts on it. My initial thoughts are, I think that could be one kind of overall framing for the hearing, as kind of a mini State of the Union in healthcare in Oregon kind of approach. But I hear that question and I hear that request. And so let us put some thought into where and in what medium that could be.
Great. Andrew?
Yeah, just I don't know if that exists. You know, you're right. There's a lot of different reports and annual hearings and other things that come out. I know OHA does do a biannual survey with a big report that might be the closest thing. But I do, as Zach said, I like the idea of somehow trying to pull all of these things together into a consolidated state of the state type of report.
Right. Yeah.
Great. Well, maybe someday we'll do that. Bill, I think that's you, Bill. I think we're ready to move on, Peter, to the value-based payment discussion.
Yeah, let's do that. And Zachary, thank you for your thoughts on this. I think it dovetails very well into the value-based compact updates. One of the things that Melissa brought up that I have not thought very deeply about and goes to this broader state of the state approach on our cost growth target is that with redetermination, well, first with suspension of redetermination, we drove more and more Oregonians into the Medicaid system, which has a different payment schedule, as many of you know. As those members are redetermined off and find their way into potentially commercial or other lines of business, we're going to see some impacts for the next couple of years from the benchmark going forward. And so there's almost a need to look at each line of business so that we can have that work for the long term, but we also need to think about the state overall and whether we're driving up costs or not, because I think we're going to start mixing and matching some things that are going to be hard to get our hands around from an analytics standpoint. So thanks, Zachary. I'm glad that you're going to do that work for us. The advisory committee, our advisory committee has asked for 2 updates from the value-based payment compact, and this is the first one. Doug introduced himself earlier as CEO and president at Samaritan Health Services. He also co-chairs the value-based payment compact work group, and he's going to walk us through some information on that today. And Doug, you're up.
Thank you, Peter, and appreciate having time.
Really tells a very interesting story.
Let me just do a time check. Lisa, do you want me to try to get through this a little bit quicker? I think, or
Doug, I think we have till 10:40 is my guess,
okay.
at least based on my original calculations. So you're welcome to take as much of that time as is appropriate. I think it's important to hear from you. We can certainly shortcut and just refer to the supporting materials within that packet. I think Sarah actually anticipated that.
Okay. All right, sounds good. And then is someone controlling the slides to get that up there? Or am I supposed to do that? I don't know.
No, can we move to the next slide, Gerondi? Thank you.
There we go. All right.
And then Doug, whenever you're ready, just say next slide.
Okay, sounds good. Thank you. And thanks again for allowing me some time on the agenda today. And as Peter said, I'm with Samaritan Health Services. Just for those that don't know, Samaritan is we're a nonprofit integrated delivery healthcare system. We actually have both a small health plan. We have hospitals and we have outpatient clinics. We're what we call an open system. So our health plan contracts with other payers outside of Samaritan. And on the provider side, we contract with other insurance companies outside of our Samaritan Health Plan. So we are open. We primarily serve the people in Benton, Lincoln, and Lynn counties. And I just want to say before we get into it that there's been many individuals that have been working very hard on this initiative. And I appreciate all their efforts. And you know, things have been stalled a little bit during the pandemic, which I will talk about, but it's not because there's a lack of work being done. So if we go to the next slide, just a little bit of background on this. So in October 2020, the Cost Growth Target Implementation Committee created a set of principles to increase the spread of value-based payment models across the state as a strategy to help improve quality and lower costs, and recommended that payers, providers, and other stakeholders across the state make a voluntary commitment by signing what we're calling now the compact, the value-based payment compact, to participate in and spread value-based payment arrangements throughout the state. The compact is jointly sponsored by Oregon Health Authority, Oregon Health Leadership Council. There's support from the Oregon Medical Association and the Oregon Association of Hospitals and Health Systems. And out of that compact came a compact work group, which is charged with ensuring the value-based payment compact is implemented. And the work group has developed a strategic roadmap that highlights challenges to the implementation, but has also identified strategies to overcome those challenges and accelerate the adoption of value-based payment methodologies across the state. You know, and I'll just say, as someone that's been working in healthcare for 25 years, I do believe we need to make the shift from fee-for-service traditional historic methodology to a value-based payment methodology. We need to incentivize other items instead of just productivity, like quality and health equity. The thing I will just note, though, is that I think value-based payment it's not a magic bullet that's going to solve all of our cost concerns, but I definitely think if used and implemented correctly, it will help us to start to bend the cost curve. If we go to the next slide, just a little bit more about the compact. I think we've had incredible success in the state with engagement and signing off on the compact. We have 46 different organizations that have signed on to the compact. This is a wide array of insurance companies, both CCOs, Medicare Advantage plans, commercial plans, companies, health systems, and clinics. Now we have about 73% of individuals in Oregon are covered by insurance companies that are part of the compact. So I think that is impressive. I do think once we some of the things I'm going to talk about today, we start to roll those out and it gets more known in the public, I think we will even get more engagement, particularly from hospitals and clinics. As Peter mentioned, I am a chair of this, the work group. We have 3 chairs though, so I'm just one of 3. Dr. Elizabeth Powers, who is a primary care physician in Enterprise, Oregon. She works for the Winding Waters Clinic. And then Dan Stevens from Pacific Source is also a chair. Ken Preventure from Pacific Source was a chair, and Dan has stepped in his shoes when Ken retired. But the work group is comprised of various stakeholders with different expertise from across the state. And I do want to specifically thank the hard and complex work done by Summer, who I think is on this call today, Chris DeMars, Laura Sisolak, all with OHA. Also, Diana Bianco with Artemis Consulting, and Michael Baylor, who's on today, is helped the work group as well. So on the next slide, you can see the original VBP compact targets. And if we could move to that next slide. These were developed back, thank you. These were developed back in 2020. These are the percentage of targets that we wanted to be payments that were value-based payments. And these are the timelines for those. That first row or first arrow is looking at all payments across the state. As you can see, our aspirational goal was by 2024. We wanted to have 70% of those payments have some form of value-based component. And then the second row, again, original goal for primary care and acute care hospitals. We wanted to also be at 70% by 2024. If we can go to the next slide, please. Of course, a lot has happened since 2020. The healthcare, clinical, and economic landscape has changed considerably. There's been the pandemic, workforce shortages, lack of access in all levels of care have slowed the implementation, and it's just been more challenging. Especially hospitals who were managing COVID levels and helping with vaccination clinics, and now dealing with some of the pandemic fallout. I always look at like the Maslow's hierarchy of needs. I think a lot of folks have been searching for food, shelter, water, and they're not ready to self-actualize. So some of this has been delayed. So the work group exercised its authority to modify the targets to make achieving them more feasible given the current environment. The timeline for achieving the targets has been extended from 2024 to 2025. You can see on this chart that some of the percentage of targets have changed as well. I think everyone part of the group that has signed the compact, and I think even a larger group of providers, even outside of that, do want the value-based payment to happen. But I think we do have to appreciate what has happened in healthcare, readjust, and find a way to keep moving forward with the momentum that we have. On the next slide, this is really just simply a final restatement of the timelines and the percentages that we're shooting for. Now, if we move on to the next slide, this is highlighting the developments of our first value-based payment model, which is going to be for primary care. As I said, primary care or hospitals, especially a year ago, were really overwhelmed with the pandemic and fallout of that. Primary care seemed to be in a better spot to start this transition. Plus, we already had an identified leadership group within primary care to begin this work. So it seemed like the natural beginning for the group. So the compact work group asked the group that's called the Primary Care Payment Reform Collaborative to create a primary care VBP model that rewards quality and equity and supports timely, coordinated, and team-based care. Now, just a little bit about this Primary Care Payment Reform Collaborative. It was established by the Oregon legislature back in 2015. The purpose of that was to increase investment in primary care and improve and align payment methodologies. So this is right up their alley. It was convened by the OHA Transformation Center and has been meeting since 2016. This group includes 32 members representing a broad range of providers, payers, and other primary care perspectives. As far as the actual clinicians, it has people from private practice, independent groups, from system groups and from FQHCs. The next slide is an overview of this primary care model. And I do want to say, I mentioned that the compact signing on to that was voluntary. Using this model is also voluntary. There is definitely a will for providers out there to get the value-based payment, but it's a scary proposition. And folks across the state have said they need help and they need direction to do it. So what we're trying to do with this model framework is not to force this on people, but it's to provide a framework so that stakeholders can start getting aligned on a payment model. And it's more about showing a way instead of forcing a way, because there may be primary care clinics out there that are already way more advanced, that have found things that are working, and we need to obviously learn from them. But this is a suggested model for primary care clinicians and payers to start moving forward. There's 4 components to this model. One, and the largest, is the prospective payment portion. The exact percentage of prospective payment will vary somewhat by payer and groups that is being served. But I think you probably all know about prospective payment or a capitated rate. In essence, it's a sort of a flat fee for the expectation of providing certain services and really managing the health of the population being served, the community being served. There is a hope and aspiration, which I believe in, that if we structure this right, that this could be effective in stopping, where sometimes fee-for-service methodology is being overused. There's still going to be a component related to fee-for-service. We recognize that there are some areas where there's widely varying rates among providers and services that are offered inconsistently, or these areas may be subject to potential underutilization with the prospective payment methodology. So examples of this may be home visits, prenatal care, advanced care, and end-of-life planning. And then the third component is infrastructure payment. This is something that I guess it's not directly tied to the provision of care, but certainly indirectly related. And this is about addressing health-related social needs and promoting health equity. Things like this could be additional care management and care coordination to support patients with higher levels of medical and social risk. It could be for providing payments for high-value, non-traditional health worker services. It could be, again, for health-related social needs screenings and supporting collaboration and data sharing. That is one, I'll just say, one of the scary propositions for primary care and hospitals is just having the necessary technology and data to make sure that we are able to manage the risk associated with this type of methodology. And then also, technology and staff to collect and make sure that we're using effectively the real data. And then the last component is a performance-based incentive payment approach, which would be paid on an aligned quality measure set to be established by the work group of the Primary Care Payment Reform Collaborative. They're convening this fall to discuss this and land on a spot with this. Their expectation is that there'll be no more than eight measures to include both pediatric and adult care, and at least one measure in healthcare equity. It's expected that the total eligible incentive payments should equal at least 10% of the value of the annual projected practice service payments, which is the capitated amount of prospective payment plus the fee-for-service amount. We can go on to the next slide then. During the development of this model, members have expressed a great interest in risk adjustment for social complexity. Certainly, I do believe healthcare is local, that it's really hard to have one prescripted methodology across the state. I think you do have to look at different populations, different communities, and look at the specific needs of those groups. The collaborative is going to convene a work group this fall to develop a pilot of implementing some sort of social risk adjustments and a better way of measuring that and understanding that. I think on the slide, most of these bullet points I've already mentioned it at this point, but I will highlight the last bullet there. While I do think value-based payment models generally incentivize providers to keep members and patients healthier, that's an inherent good of this model. There is, I think it's also possible that value-based payment models can have unintended adverse consequences, including withholding care, discouraging a panel of high morbidity patients to seek care, or maybe even referring patients out of primary care to specialty urgent care or EDs, which, that's an even more expensive point of care. So I think we have to go into this eyes wide open, and we have to be cautious around this. Some strategies that we're going to be looking at is making sure that we're using data to identify early indicators of decreased access if there's that. No one wants decreased access. I mean, I know in our 3-county area, we absolutely want to improve primary care and behavioral health access across the 3-county area. It's one of our highest strategic initiatives, and I think that's pretty much the same around the state. We're going to have to adjust payments in some way so that practices that treat patients with higher medical and social complexity are paid more relative to those that do not. This can't be a financial devastating methodology for providers, especially small primary care clinics, or they just simply won't make it. The margins are thin already. And then we're going to have to track closely the patterns, referral patterns to specialty care, to urgent care, and EDs to just make sure if there are some observed outliers that we have a way to discuss that, be transparent about that, and learn from that. We can go to the next slide now. So I've been talking about the proposed primary care model. In conjunction with that, the work group has also been working on a toolkit. One of the things that we heard early on is that many organizations and groups wanted to do this, but just did not have the practical tools, resources, and expertise to convert to a value-based payment model. And that if we could help provide some sort of toolkit for that transition, that would be extremely positive for them. So we've worked on that. Again, I'll just say again that no one is absolutely required to follow the toolkit. This is meant to be a resource to help folks and provide assistance where needed to incentivize movement to value-based payment arrangements. This is going to include the main thrust of this is actually going to include just some basic definitions, the vision, the why of why we're doing this, and then some educational resources, including case studies. And part of this is highlighting partnerships across the state where we've had these methodologies and they have worked well. And then how can we all learn from that going forward? So the collaboration is key. If we move on to the next slide, this is a checklist that's in the toolkit to understand these models and the basic terms. And part of it too is just to do an internal kind of environmental assessment of where you're at. Are you ready for this? If you're not ready, what's the gap to be doing something like this? Truly understanding how attribution and assignment is going to work. Understanding better your population and some of the health disparities that you need to be thinking about now. And I think this is obvious, but I'm going to state it because it is a paradigm shift, especially for providers. We tend to think of healthcare in terms of taking care of the sick and injured when they present themselves to us, which we always need to do that. We can't lose sight of that. But we do all need to start thinking more about community health and population health and how we can work globally and go more upstream to prevent some of these sicknesses from happening in the first place. So folks need help in making that transition, and then certainly understand the financial risk that's associated with this Then on the next slide is kind of more of, okay, we've done the assessment, we've figured out some of the gaps and the basic principles of this. Now, how do you start to really get ready for this within your organization? And you know, how do you engage your leaders to get ready for this? You know, if you work for a corporate organization or even a nonprofit organization, how do you engage your board members to get ready for this? How do you truly leverage data? I've already mentioned how important that is to being successful. Planning, doing your financial modeling to make sure that you're getting ready for that risk and have strategies in dealing with that risk. And then, you know, using this as a way to negotiate and engage with payers, and payers are going to be using this. This is going to be available to payers as well. It's not meant to be any secret sauce on one side, but really alignment tools where different parties can come together and collaborate and work on these partnerships. And then the next slide is again more of the checklist that's inside the toolkit. And how we go live with the value-based payment. And you can see the bullet points here. I just want to mention that this is a scary proposition probably for payers, for providers, and for our policymakers, right? Probably for all of you on this committee. We absolutely have to make this a learning process. So if there is success, why? Is there failure? Why? How do we learn from these arrangements? And making sure that if it's not happening as anticipated, that we have the flexibility, that we have the shared collaboration, that we have the data to pivot and change it so it is more of a win-win for everyone. And then on the next slide, the last part of the checklist, again, this initial model is for primary care. And we chose that because of things that were going on with the pandemic. But in retrospect, I think it was just the right approach overall. I think it would have been a lot to try bite off all of these different areas and have these models for all of these different areas for right off the start. So we're starting with the primary care model. The idea is eventually we want specialty care models and hospital care models as well. I think also the group has been talking and the collaborative of the primary care physicians have been talking. You know, there may be a way to look at this in these big buckets like I have on this slide, but also look at this in just maybe discrete clinical service lines or bundle payments or, you know, other types of things like that. I think that we could look at to see if it works in a value-based payment scenario. Then on the next slide, we're in the process of disseminating the primary care model and the toolkit. We have I think a really good website that you know, all the OHA folks that I mentioned before and some of the consulting helping us have I think just done a fantastic job of laying out a lot of this information in a really easy to read format on the website. We'll continue to promote the model with CCOs, with OEB, other payers, and obviously the providers as well. And then, as I mentioned, we'll work to develop payment models for some of these other settings of care as well. So that is, I hope I did okay timing there. That is what I was going to talk about today. I'm happy to take any questions. I will just say that although I am on the Compact Work Group, I'm not directly involved with the primary care collaborative that's working on this. So I'm a little bit of disadvantage on maybe some of the detailed questions that you may have, but I think Summer's on and other OHA staff can help me with that. But fire away if you have any questions.
Doug, I want to thank you for your work you're doing on the Compact and also for this presentation. You know, we talk about the how, and this is part of the how we get our work done here. It's pretty impressive, the level of detail that you've outlined in some of the supporting toolkits that you're providing. As we think about this work, I think some of our obligation is to take some of our commitment as leadership of both payers and providers and really drive that down into our organizations for those folks that are doing the daily work of negotiating contracts and thinking about payment in between organizations. Sometimes there's a gap there, and what it's going to take is for all of us to start talking about the fact that we're moving in this direction. I'd love to take some questions for Doug if anybody has any.
Well, let me just say, Peter, I appreciate those words. And I will also say, you're exactly right. As we've been on our journey with this, I think that I had that one, there's that part in the toolkit about engaging leaders. I think, everybody in, a medium-sized to larger organization, folks have their roles, and they've generally been in those roles for a long period of time, and they are subject matter experts in, doing contracts with payers or doing contracts with providers and assessing risk. This is really a paradigm change. And I think it really is hard to get understanding, buy-in, and that creativity to move forward with these changes. It's going to take a while. I don't think we should take any of this change lightly. And I think it's just a really good point that you brought up.
Lisa?
Yeah, I feel like there's a couple of things I think here. I understand that this is voluntary, and I understand about the pandemic, but I feel like we're not fundamentally making progress on people implementing these things. And so if we go back, I think the slide that was outlined during Zachary's presentation around where the market is at across the board on different types of payment, if we took that slide and applied it to PEB and OWEB, which have had this for much longer than the value-based payment compact, and we haven't seen movement, I feel like my question here is, do we actually fundamentally feel that with this, and this is the only direct strategy that we have that is about payers and providers sort of lowering cost, and to Michael's point earlier, what are we actually going to change to do things differently? Do you think with this toolkit and these really direct sort of tools that you think we can see that, I can't remember the target movement, but I think it's 33%. And if somebody can remind me what we're at now, we're not even close to that number for most payers.
Gerondi, can you go ahead 2 slides? We have a market snapshot of progress towards the target. This one. Yep.
Okay. So when you look at these categories, like we're not close to those numbers. So do we feel like the toolkit is going to drive us there? Or?
I think, Felisa, I'm sure others have, so I'll just take a stab at this. So and I did mention voluntary a few times. So, but I will say everybody knows that these targets though are reality, right? So it's just what's your approach to get there? Is it using the model? Is it using the toolkit? I think, especially the smaller clinics out there and smaller hospitals, they desperately need help to do this. I truly think there's a desire to do it. They just honestly don't have the tools, the data, the know-how to do it. So I think we've got to have something like we're doing with this. So I think the toolkit and the model will help. And I promise you that that is going to be the magic bullet that gets us there. I don't know. But I think the other part of it is purely the engagement. I think, you go back to that, you don't need to actually go back to the slide, but I think it was like 47 organizations have now signed on to the Compact Charter, have been engaged in some way in this work group. I think that engagement is good change management, right? You get a lot of people involved, you get a lot of people that are there to give their feedback and ask questions and give the input. Will help us as we're trying to kind of push over the finishing line to meet these targets that we have. So I think is it everything we need to do? I don't know. Do I think what we've done is absolutely necessary if we aspire to move it at all? I do believe that. And I think we are heading in the right direction.
Well, I guess on the, oh, sorry, Peter, to jump back in. I feel like this brings me back to the September meeting and the panel that we're talking about and having that different mix of payers is I feel like one of the questions that I would have for that group is what is holding you back from getting to that 35 to 40, actually 40%. I mean, we're supposed to be at 50% now, even though we've adjusted the targets. What is holding you back from getting and implementing value-based payments? Because and I think the providers who are on that panel, we've had that many organizations on all of those panels, both on the commercial payer side and on the provider side, have signed the compact. And they signed it years ago, and and then there are 3 of them at least, right? Providence, MODA, Kaiser, who participate in PEB. And they have not reached those goals either. And so they've had it for a while.
Can we go to the PEB slide? We have the data in detail by market. So here's Medicare Advantage, here's PEB and OEB, and the next slide is commercial without PEB and OEB. So just toggling back, you can see there's some big variations.
Melissa, you had a comment?
Yeah, I think, you know, the land categories continue to evolve and grow in this model. And when I understand this and look at this, and as far as, you know, speaking as a provider, but also recognizing we have a partner with a health plan at Providence, we have all of our agreements, I think I can confidently say, have components of this, but they actually fit in like a 3N or a 4N category. So there's kind of full risk and agreement. So some of it is also, you know, as these categories evolve, maybe that's some of the programmatic work too. So there's a 4N and a 3N category that I think, you know, inherently when you're sharing full risk, quality is a component of that. Rather than gating it. And so I just wonder also maybe if there's some understanding within the program around the categories and the evolving within the land framework that movement needs to happen on. I don't know that, but that when I kind of looked at this data last week, I was concerned because, you know, how I work and understand our contracts with our health plan, this doesn't fit. You know, we're kind of every day looking at cost, every year, every month, you know, reconciling where we're at in performance and paying, you know, attention to this. And so, you know, upon further review, there's other categories that kind of are even further down the spectrum. I just don't know how the program has evolved or if it has in recognition of those land kind of continuing refinement of those land categories. So I think, Felisa, maybe there's some opportunity there, right or wrong. I think there's some opportunity there.
I appreciate that. And Sarah, would you include maybe in our next packet or maybe in the chat the updated alternative payment methodology framework so that people can maybe refer to that in the future? Category 3 is essentially built on fee for service with shared risk, with up and downside risk. And then there's some other categories as Melissa talked about. Category 4 is really population based, and you get into specific PMPMs per member per month for specialty or total global cap, as in some of the Medicaid issues that are CCO opportunities that we have. So thanks for that. Ali, you had a comment.
Oh, thank you so much. Yeah, just a couple comments. There's definitely been some challenges for just speaking for PEB and OEB recently around VBP, but we've really recently got both boards to re-up on their commitment, and we've actually implemented performance guarantees in all of our contracts with our carriers with fairly significant fees at risk, and so we fully expect to see those numbers now, you know, breaking through that 50% mark, and you know, we're again speaking for the boards, they're fully aligned with the VBP compact, and we'll do whatever is necessary to help contribute.
Appreciate that focus from PEB and OEB. Certainly, as financial stress has impacted large provider systems. There's been a lot of concern about opportunities for downside risk, et cetera. And so we may have seen some variation in the trend. Hopefully, Felisa, we're not seeing a change in the trend. We're just seeing some variation for the time being, and we'll get back on track. Summer, you actually had your hand up before we jump to Doug, and then we're going to cap this off.
Sure. I just wanted to note, and this is, this trickiness of claims data and the delay. We all know about how claims data is. And so I think if you could go back a couple slides, to one more. Yeah, there we go. So I hear you, and Felisa, that we're not meeting the targets at the same time, but this is where we are in 2021, and the 2021 target for all percent of all payments in that shared savings category or higher is 35%. And so everyone is meeting that, except commercial is at 32, so it's under. That is 2021. Don't know what it looks like in 2023, and in 2023 the target is percent. And I can't say, I don't have my finger on the pulse of where we are right now. So whether whether payers have made enough progress to get from where they are in 2021 to that 50%. So I think we could definitely do more, and we're not totally off track. When you get into the looking at 3 shared risk or higher, specifically for acute hospitals and primary care, we're still working on being able to break out that data, especially around hospitals, and so that very well could be under that target, which today is in 2023 at 40%. So it's hard to know for sure as of the delay in claims.
Thanks for those thoughts. Jessica?
Yeah, and I'll be quick, because I know you want to move on. One piece that I see here is we're missing the third piece of these types of agreements. A lot of times we talk about the payer and provider, but in the commercial space, especially the ASO or self-insured space, the employer might have the option to opt in. So I think they're a big piece of this conversation, and our ability to talk about the value of these programs, which is why you might see the numbers a little bit lower, where the individual is making the decision and the payer takes on the risk, and the payer and provider are the two in these contracts. Those might be a different type of conversation.
That's a great point, Jessica. Thank you so much. ASO always stands out. Administrative services only, self-insured employers. Felisa?
So then I think on the exchange, so I assume that all of the exchange plans are meeting the target? Do we know? Are all of the exchange plans meeting the target?
So we're measuring for the commercial market. So if we go back if we go forward a couple more slides, this is across all of the commercial payers, various plans, including their marketplace plans and other plans. So I don't know that we have detailed data. Andrew, Summer, my team, I don't think we have an answer to that question.
I don't. The Cheeky in the marketplace might be able to get that. They're the ones over at OHA that have the contracts in place.
So I just think that I think to Doug's point about how this is like a very big change, that it is a hard change to make, that it needs to come in incrementally and stepwise. I feel like we've had it for a while now. I think what might be good is for us to break down some components where we could drive this in some places that get us to bigger change, right? Breaking down a big, scary change into smaller changes might help with the implementation. So I think PEB and OEB have done that, and they're committed to sort of following that path. And so implementing that path to get to these target numbers within PEB and OEB. Could we be thinking about that in the marketplace? So we think we break down the commercial market into, we're going to start with the exchange marketplace. Then we're going to start with having this conversation with businesses that are large employer businesses. And then you can tackle self-insured instead of trying to boil the ocean a little bit to help us sort of reach these targets in a way. And I don't think that was the toolkit that Doug laid out, I feel like is helpful into getting there and especially having those conversations. But maybe there's a point where we could just break it down a little bit about having goals and implementation in these different components.
That's great. Thank you so much. Doug, I appreciate you both presenting and then hearing some comments back for the compact as you kind of think about this. I think, there are some structural changes that would have to happen to start looking at this by product within lines of business, but maybe that's really a way to think about how do we drive this change that's really required. And so I really appreciate the discussion today. In the interest of time, I'm going to cut this off. Thanks for attending. We're going to ask you to come back, or one of your colleagues, Doug, to come back and do this again before the end of the year. And we really appreciate your time and attention to this hard work.
Thank you for your time and thank you for all your feedback. Have a great day. Bye.
Sarah, are we back to you and your team? Oh, no, we're back to a break. What do you want to do about a break, Sarah?
I think we are close to on time. So what if we take a 10-minute break and come back at 11?
That's perfect. We will see you all at 11 Pacific time.
Because buckle up, we're about to talk about accountability. So I think I want to start this conversation by, I think oftentimes we think about accountability as something that is negative. And I really want to start by saying accountability is a feedback loop. And the way that we think about organizational accountability and accountability as individuals is it's a feedback loop, right? You sort of are on a path, you're reporting data, things are happening, and then, okay, you're not meeting expectations. Well, there's accountability to help us get to meet those expectations. And I really think that's true with performance improvement plans. And I hopefully think that will be true in the sort of joint learnings. And I think hopefully we'll get some of that out of September, right? I think that we've seen that the vast majority of our market is committed to the sort of 3.4% cap, and that we are really trying to drive towards that. And so when we think about accountability, it's going to help us meet that. And it really is to focus on outliers. And there is a lot of flexibility in getting us there before there are actual penalties. And so I just want to remind people that the accountability, the PIPs, the financial penalties were codified into statute in 2021. And so, I think we've made some adjustments on when those come into play based on the pandemic and the areas, and that we've agreed to the delay. But we're headed into January. In January, we agreed to delay, but now we're headed into more accountability. So we want to pop up the slides. So I want to be clear that there's nothing to vote on here, but I think that there's a lot of input. There's places for input or ideas to help shape what the staff are thinking as they move forward about the implementation around accountability and what that looks like. And I would encourage folks to think a little bit. I know we try to come to this sort of thinking, bringing our organizational expertise. And I think this is a place for that, is how does accountability and the performance improvement plans motivate organizational change? before we get to that penalty phase. So am I turning it over to you, Sarah? I have a list of people. Great.
Yes. Thank you for that intro, Lisa. So this is the first time in a while that the advisory committee has talked about accountability, and I'm going to provide just a quick recap, regrounding in what the accountability mechanisms are and how they work, and then some more of the team is going to talk about the details. So I think I also just want to recognize that, as Felisa said, the performance improvement plans, or the PIPs, and the financial penalties have been codified in statute based on the implementation committee's recommendations. So recognizing that we are a different committee, this is a different group of people. Some of you are the same and were involved in that, some of you were not. So I think as we are developing this, just recognizing that this has been a long conversation over a couple of years, and this has also been an evolving conversation, and some changes and adjustments have been made. But the framework is still the same. So let me start with that on this current slide that we have up. So just talking a little bit about the process and some of those flexibilities that Felicia mentioned. So before any payer or provider organization is held accountable for cost growth that exceeds the cost growth target, we are going to do a couple of things. We are going to ensure statistical confidence. So only payers and provider organizations that exceed the cost growth target with statistical certainty can be held accountable. So if there's any question, if this is, maybe due to small numbers or noise in the data, that is going to be weeded out before we get to an accountability conversation. We will also have conversations to understand the reasons for exceeding the cost growth target. The reports and the public hearings are all part of that, but this is really about the transparency and the collaboration and understanding. Many of our conversations with payers and providers in reviewing data and validating data have already gotten to some of those. The payers and providers can come to those meetings, and they do, and they say, we had one really sick kid, and that was the reason our costs were above the target this year. And so having that understanding and that collaboration to that shared understanding. And then finally, we have those the PIPs, but then if over several years an organization continues to exceed the target with statistical certainty and not for a good reason, which we'll talk about in a second, we have financial penalties. So this was a deliberate choice that the implementation committee made. It was actually in their direction from the previous legislation that we couldn't just have performance improvement plans. The legislative intent was very clear. Oregon needed to have performance improvement plans and something else. There needed to be something beyond that. So this is all what led to our current structure and having performance improvement plans and financial penalties. Next slide. So as I said, we will have these one-on-one conversations with any payer and provider organization that exceeds the cost growth target before we get to a determination of accountability. That includes sharing data back and forth. That includes having conversations. And there's our sort of shared responsibility with both OHA and with the payer and provider to participate in that and to understand what's happening. Next slide. We also have a whole set of good reasons for cost growth that might be above the target. And this is something that is baked into the program, and it's something we'll be continuing to codify in rulemaking. We shared a draft of these reasons and some additional details about them with you all back in November. I can share that link later, but just as a summary, some of the good reasons. Changes in mandated benefits. So if state passes legislation and says insurance plans now have to cover something, and that something turns out to be really expensive, that will be a good reason for exceeding cost growth. No payers would be held accountable for that. If there are other changes in federal or state law that affect costs, if there are acts of God, to use some insurance terminology, so pandemics, natural disasters, we know fire has been an issue. All of these things can have an impact on healthcare costs. If there are changes in taxes or other administrative factors that influence how healthcare cost growth might be playing out, that's something we would take into consideration. If new drugs or treatments are entering the market, we know, I think our big example here is when the hepatitis C drugs entered the market a few years ago, they caused a huge increase in costs. So again, none of the intent is that anyone would be denied access to care or access to treatments or services. And so no payers or providers would be held accountable for this. Investments to improve population health and health equity. We know there's a lot of focus on addressing social determinants of health. providing health-related social needs services on the Medicaid side, things like investments in primary care, investments in behavioral health. Those are things the state is prioritizing. And if those are the reasons that a payer or provider organization is above the cost growth target, also no accountability. Macroeconomic factors. We know there's a lot been happening with inflation recently, and keeping a close eye on some of those market trends. And then finally, we have a new addition to the list in this legislative session that just ended. House Bill 2045 added a new exemption or a new good reason for excess costs. So if a provider organization's frontline worker costs are the reason they exceeded the cost growth target, accountability would also not apply. So there's a lot of details in all of these, and there's a lot of questions about like, well, what is exactly the rule, or what is exactly the detail that would, cause it to be reasonable or unreasonable? And I think we might never have sort of a complete comprehensive list. This was always intended to be flexible to account for unforeseen changes, things that are happening to the system, but to come into these conversations and this process of accountability, determining reasonableness with that eye towards flexibility, recognizing that there are reasons for cost growth that are within payer and provider control, and that is what we want to be focusing on. Next slide. As Felisa mentioned, our accountability timeline is phased in, and we have agreed to delay performance improvement plans by 1 year from the original timeline. So we are currently in sort of cost growth target year 1. We've reported and published the data in May. We're having public hearings. Payers and providers have been publicly identified for the first time, but we are not looking at performance improvement plans and financial penalties until a few more years out. Next slide. That said, we do know that payers and provider organizations are actually pretty anxious about accountability and sort of not knowing what this looks like. And so even though we still have a few more years on the timeline before some of these things fully roll out, we are doing the development work now. And we are planning on doing rulemaking later this year and really baking some of these accountability mechanisms so that payers and providers have certainty and have some more insight into what this process looks like. And we relieve some of that anxiety of the unknown. So this is our development timeline that we are currently working on. We've been sharing some early drafts with the technical advisory group in May, June, and we'll do that again next week in July. We are sharing with you all today. This is the first time we're bringing this to you for feedback. Later this summer, we are going to launch recruitment for a rules advisory committee. That's a whole separate process for administrative rulemaking. We'll be doing that rulemaking in September, and then there are a number of steps that follow to codify all of that rulemaking. So we will be launching recruitment. So as Felisa said, this advisory committee is not the decision maker for this, but we really do want to use your expertise and your perspectives to collect some feedback right now, inform the drafts, inform how the performance improvement plans and the financial penalties methodology is shaping up. And we will use that to inform what we bring to the rules advisory committee later this fall. Next slide. So just a little quick bit of national context. So different cost growth target states have different levels of accountability based on their establishing statute or executive orders. All states have public reporting, transparently reporting payer and provider performance by name. Massachusetts has public reporting and performance improvement plans. That's where we got the performance improvement plan idea from. California and Oregon have public reporting, performance improvement plans, and financial penalties. So California is a newer cost growth target state. They're a few years behind us in the timeline, but this is what's in their legislation and this is the direction they're headed. So we are currently on the sort of upper range of having this full toolbox of accountability mechanisms. Next slide. And like I said, today we're asking for feedback. So with that, I'm going to pause and see if there are any questions just about the background of this before I turn it over to Zachary and Stacy to walk you through the details. Jessica, I saw you had your hand up a minute ago. Question, comment?
I can wait until we go into the feedback session. So thank you.
Okay, then I think I'm going to hand it over to Stacy to talk about the performance improvement plans.
Hey there, can you hear me? Great, okay. My name is Stacy DeLong. I use she or they pronouns, and I'm a policy analyst at OHA supporting the cost growth target team. So I'm going to go through some high level slides on the performance improvement plans, or PIPs as we like to call them. Okay, so when are PIPs required? So as Sarah mentioned, PIPs are an accountability mechanism that will phase in with the 2025 reporting. That'll be for data submitted in 2024 and cost growth from 2022 to 2023. PIPs apply only if an entity has exceeded the cost growth target with statistical certainty and without reasonable basis. And the reasonable basis are those reasons Sarah went over on slide 45. So this means if an entity exceeded the target for an acceptable reason, such as new drugs or treatments, they wouldn't be subject to a PIP. Next slide, please. So the goal of performance improvement plans is to help entities meet the cost growth target, and particularly meet the target in future years. So OHA will collaborate with payers and provider organizations to develop the PIP. This collaboration can include providing feedback and technical assistance throughout the process of PIP development. The PIPs identify and address cost growth drivers. The entities are going to submit PIP progress reports during the PIP period. The frequency of those progress reports may vary based on the PIP timeline. So depending on the strategies that an entity is looking to implement, the timeline may vary for the performance improvement plan. And then PIPs and progress reports will be made publicly available. With those, confidential or business sensitive information can be redacted from public posting. And in the drafts that we have outlined some processes for that as well. Let's go to the next slide, please. So this slide shows some of the required elements of a performance improvement plan. So drivers of healthcare cost growth, what's driving cost growth for that specific entity, overall goal for reducing cost growth that includes a dollar amount for savings that will be achieved, strategies to contain cost growth, and these are specific actions that will generate savings or contain costs. And then we want to see clear metrics for success, and this includes both metrics for measuring kind of progress on a strategy and also balancing metrics that measure any negative effects of that strategy. The PIPs will include an appropriate timeline to reduce cost growth. And as I mentioned, the timeline may vary based on what's in the content of the PIP. And then we'll also include any technical assistance needs. So what support an entity might need in order to implement their strategies successfully. Next slide, please. So this slide gets into the PIP development process. So there's guidance that OHA will publish, documents, templates, examples that entities can reference when they're required to do a PIP. Technical assistance, so this could come in the form of webinars, published resources, providing feedback to entities during their PIP development process. The PIP submission, so entities have 90 days to develop and submit their PIP. And during that time period, they can submit a draft to OHA for feedback. And OHA can review and provide feedback prior to submission. And then after a PIP is submitted, OHA will review and either accept the PIP or require a resubmission. And if a resubmission is required, OHA will provide information and guidance on what is needed for the PIP to be accepted. Next slide, please. So this slide shows what is in the PIP template, the current draft. Those drafts were shared for this meeting. They have a lot more detail, but at a high level, these are some of the key elements that are included in that current draft. So it'll include projected savings for each strategy, and that's a dollar amount. Key activities to implement the strategy. It'll include strategy measures, which are going to measure progress toward that strategy, balancing strategies to avoid negative impacts. So any sort of negative consequences or negative impacts that might be associated with the strategy. This could be negative impacts to quality or access or equity. So that would list out strategies to kind of mitigate any negative impacts, and then balancing measures that would measure those balancing strategies. It'll include a plan for strategy adjustments. So as the PIP progresses, how might you be adjusting to ensure that you can achieve your strategies and avoid negative impacts? It'll include a section about how the PIP will benefit consumers and purchasers. What is the plan for generating savings? Any partners that will be engaged in implementing the PIP, and then any dependencies, any things that have to happen in order for strategies to be implemented successfully. Okay, next slide, please. So that's kind of a quick high-level overview for what we currently are proposing for the PIP. So as I mentioned, we shared those documents. We're seeking feedback on what we've proposed. You can email your thoughts. We have the email address listed here. We would love to receive those. As we mentioned before, that we are going to be starting to recruit for a RAC and start the rules process. So getting the feedback in the next 2 to 4 weeks would be great. And some of the things we'd like to know in particular are whether or not the process is clear, whether the timelines seem reasonable, and then also what types of assistance entities might need as they're going through a PIP process. One other thing I'll note is that we have.
Stacy, can we jump in just a second? I think Julie has her hand up, so she might have a question.
Sure.
Oh, yeah, I didn't mean to cut you off, Stacy. I just really quickly, if you could go back and help me understand what you mean by statistical certainty. Do you mean statistically significant? Because there is no certainty in statistics. So I'm just kind of curious how you guys are defining that.
Sure. I am going to actually punt to Sarah if on the statistical certainty piece.
Yeah, sure. So I'll drop some more info in the chat for you, Julie, but we have a whole process where we run some statistical tests about cost growth and calculate confidence intervals and use that to determine whether or not an entity is above or below the target. So if the confidence interval overlaps with the target, then we wouldn't say that, we can't say whether or not they've met the target with any certainty. It's essentially a statistical significance test. That's okay. Statistical certainty is a slightly more friendly way to say that. We have very detailed write-ups about how we do all of that if you're curious.
Okay, not really. I was just curious about the term because it's kind of, counterintuitive, but I appreciate it. Thank you.
Peter, do we want to kick it? Do people have questions before Stacy continues on that feedback portion? So Peter, jump in and then.
Yeah, I'm just going to jump in with a quick question, and it's sort of the unintended consequences question, Stacy, which is, as you think about Oregon, we have a very unique market with an awful lot of payers. It's different than the other states that we do business in, or some of the other states we do business in. And I think it's an important component of our work. Market share becomes an important element of being able to negotiate sustainable, both value-based payment contracts and rate contracts. Do you think that the process of the PIP and or the accountability potentially puts smaller players, smaller local players at risk versus some of the others that either have vertically integrated systems and or larger market share in some regions through this process?
So making sure I understand, so it sounds like you are raising that the process has more, it will be more burdensome for smaller players than for larger players. Is that kind of what you're getting at?
I don't know if it's the process or the, obviously there's some administrative costs that impact smaller players more than others. I just wanted to think more about smaller players that don't have potentially the market share and the ability to drive contractual accommodations that would allow them to maybe meet these targets in the future. It's just something I've been thinking about.
Yeah, that's something we should consider, that we can consider as we're developing this. I think one of the reasons we're asking about the types of help entities we'll need through the PIP process is really to kind of get at this piece, understand the different types of technical assistance that different players will need. We know providers and payers will probably need different supports through a PIP process. Their PIPs will look different. And so we want to understand from this group and from the tag what that might look like and how the PIP might look different for them.
You bet. I just think it's important to think about what consequences we're trying to drive. And I think the discussion of accountability and the purpose for it was really good at the outset. What I would hate to see is an unintended consequence of, pushing towards either national payers or something of that nature. I don't know that this does it, but it's just something that we should think about as we develop some of the processes so that we don't fall into some of those traps that are out there.
Great, thank you.
I think that is kind of the outset of what I was saying at the very beginning, which is when we understand what the per capita spend is, we're kind of comparing against other states. We do have such a unique marketplace. And so that context is important. And to Peter's point, we want to make sure that we are able to maintain, the environment that we have in Oregon that has historically allowed us to have, less healthcare spend maybe than other states that are focusing in this area. So I of course, the devil's in the details on the PIPs and the data that's required and what's really meaningful. And as a provider organization, my head starts spinning to think about, well, is a cost driver increased length of stay, and is length of stay in my hospital because there's no place for the patient to go because of external environmental factors? And then how do I, there's a lot of pieces when that patient is in the hospital that are driving costs the devils will be in the detail around kind of this and reporting and performance and how we understand that. But that's, I think, a concern is making sure that as we go through these, that what we're providing is meaningful, and really, and it's such a complex environment, and kind of what drives costs. And so how that comes together, and I think what you laid out before and kind of the focus makes sense, but the detail around what that really means, I think as we go through this and there's discussion and planning and partnership on how that comes together will be really important.
Thanks, Melissa. It looks like Jessica and Felisa, you've got your hands up.
Felisa, you want to go first?
Sure. Yeah, I just think I have a couple things. One, I think we should put a pin in a future conversation as we get into PIPs and accountability, and whether people are meeting the conversation about if we do need to have a conversation about payer-provider relationships to achieve the cost growth target, if we get there as a board. Because I think some of those strategies around changing those dynamics can be legally limited. But I think we should think about what that looks like. The other thing I think is on the list of the sort of technical assistance, guidance pieces and resources, and on the strategies. I think what should be taken into account is the other programs that how are people implementing the other programs that our state has to reduce their costs? So I think about how have they, or I'm not articulating this well. So have you implemented value-based payments to the full extent that you can? And you've signed on to the compact to reduce your cost. And so what does that look like? Have you implemented the primary care payment model that our state has, but and to the fullest extent that you can to control your costs. Have you, like, the other components that our state has put into place, or have you implemented the sort of implementation on primary care so much that it actually has driven your cost up and you're just really driving people into primary care like a maniac? And I think that outline here, I feel like including some of those key components in this template for each strategy or in the developing a PIP component.
Thanks, Felisa. Jessica?
Thank you. One of the things I think that will be important is some flexibility as we go through this process, and equitable across the different reporting organizations. One of the things that jumps out to me, obviously, HB 2045 talks about, you know, the cost of healthcare and what can be kept out of the provider reporting or is acceptable. A lot of times when we're talking with providers and they ask for increases, they'll say that, you know, the cost of nurses and supply chain and all of that are impacting that, but we have no way of knowing how much of what they're asking for in an increase is specific to that. So we don't have a way to keep that out of our reporting. And there'll be other places where those things come up. That's one that jumps out now that we all see clearly. And each organization is going to have different drivers and different pieces, and making sure we're equitable across all the groups, I think is going to be difficult and something we'll have to work through and work really closely together on, especially in the first year or two of these PIPs till we all kind of settle in. For those of us who were a part of the healthcare reform and the ACA, the Affordable Care Act coming out, there's a lot to work through in those initial years. So I think us coming together as a group and working through those things is going to be really important as we move through this process. But overall, supportive of a PIP holding us all accountable.
Thanks, Jessica. I want to jump in for a second and say that I think some of these comments are more about that determination of reasonableness part of the process, and that conversation, that sort of back and forth about what are the cost drivers, were they a good reason or not, were they frontline costs that were passed on through rate increases, like all of that happens before we get to a PIP. So I think the way that we're envisioning this is by the time we get to a PIP, those conversations will have happened. If there were good reasons, we're not even talking about a PIP. And if we are talking about a PIP, there's already been some shared understanding of what those cost drivers are. I think to maybe some of Melissa's point about the inpatient costs, like, and an organization should know by the time we get to that point that, like, yes, based on all the data that we've looked at, both on OHA's side, on the organization side, it looks like inpatient costs are your primary cost driver. And then maybe the organization has to do a little homework and say, was it due to length of stay or not? But hopefully that would all be worked out. So I think I want to reflect that what I'm hearing is still a lot of anxiety and feedback about that part of the process and less about the PIPs themselves. So valid, fair, please give us all your feedback, but just sort of separating those out. And Felisa, I see your hand, but I also want to make sure that we leave some time for Zachary. So you get last word on this, maybe.
I just have one other component of the PIP submission. Maybe it's PIP submission. I feel like, and to Peter's point around national players, so it's us in California who have accountability standards, but we have a bunch of different states with cost growth targets. I think part of the PIP conversation should be, and what is part of their submission and acceptance is, are they bad actors across the board? Bad actors is maybe wrong, but like, are they doing, because I think there's this piece, right, where like we have one group who didn't submit their data to Oregon in our report. Did they not just submit their data to us, or did they not submit their data to every other cost growth state? Are they out of step just in Oregon, or are they out of step in every other state they're operating in? I think that should be taken into account in the process for getting to a PIP.
Okay, that's all we had on the PIPs. We can also summarize the feedback that we received via email through the tag or through this group and report back. Thanks all. I'm going to hand it over to Zachary to talk about financial penalties.
Great. Thanks so much, Stacy. Just as a reminder, hi everyone. I'm Zachary Goldman. I'm on the OHA team, Healthcare Cost Economist. Gerondy, please let's go to the next slide. So I want to dig into financial penalties. I'm going to try to make up a little bit of time because I mostly want to hear from you all. So I'm going to stay pretty high level. And here we go. Okay, let's go to the next slide. We already talked about the fact that financial penalties are already required by statute. I'm not going to read this, but this language is here for everyone's reference. Let's move to the next slide. I want to ground us in, we've already said this, but just to reiterate, so these penalties, they only come into play when 3 conditions have been met. The payer provider organization exceeds the target in 3 out of 5 years, 5 sequential years, with that statistical significance that we talked about, and without an acceptable reason. And Stacey already talked about that. And there are kind of back-end guardrails that I'm going to talk about that ensure financial penalties don't threaten any kind of solvency or put anyone out of business. That's not the intention here. Let's go to the next one. In terms of process, there's been a lot of really good engagement thus far. So OHA staff presented initial penalty options, kind of conceptual ideas to the technical advisory group. Some of you may have been listening into those in May and June. And we heard input from payers and providers, and that was really helpful. These options that you're going to hear about incorporate some of these ideas from the TAG members. So that's been really helpful. And TAG members specifically asked for some examples, like how would this kind of tangibly, what would this look like? So we're working on some examples and we'll be sharing those when we have them. Let's go to the next one. There are 3 methodologies, 3 kind of conceptual ways to calculate a penalty that I want to talk about today. One is based on overage, and that calculation is using the adjusted growth, the PMPM, and the number of members. So it's kind of all 3 variables, if you will. A second that I'm going to talk about is as a percent of revenue. So that would include kind of a penalty schedule, like an external thing that we publish, and the entity's revenue. And third, on the basis of a per member month. So it's almost like a flat rate, if you will, but scaling up and scaling down based on how far over you are. And so that's based on some kind of schedule amount plus the number of members. There's pros and cons here, and I'm going to talk about that. And there's different kind of methodological considerations we should talk about. So that's what we're going to discuss today. And let's jump in. Let's go to the next slide, please. So option 1 is based on overage. By overage, I mean how far over the target you are. So if someone's coming in at 6.4% growth with statistical significance without a justifiable reason, that's 3 percentage points above the 3.4 target, right? 6.4 minus 3.4. So it's based on the PMPM, so how far over the PMPM you are. The good thing about this is it's really simple to calculate. Administratively and just in terms of transparency, it's pretty simple, right? The downside is there's no kind of built-in upper bound. Let's say the PMPM is some exorbitant number, like 25% or something. 25 minus 3.4, that's a big number. So if the penalty is based on that, that's going to be a large penalty size. But remember, there's some back-end solvency protection, so that would drastically deflate that value, which we're going to talk about in a minute. Staff are currently leaning towards this option, and we're really interested to hear thoughts about this and what folks think about it. But this is what I'm calling the overage calculation, so based on overage. Let's go to the next one. Option 2, this is really different. Option 2 is really different. So it's based on a percent of revenue. So it's calculated by multiplying revenue by some kind of penalty schedule. So imagine a schedule that's like, if you're over the target by only 1 percentage point, right? You're at 4.4% with statistical confidence, without a justifiable reason, in 3 out of 5 years, et cetera, et cetera. If you're over it by just that 1 percentage point, say it's 0.25 of your revenue, or some value. But if you're greater than 10 or 15 percentage points above the revenue, then it's 3, 4, 5%, whatever those percentages are. But there's some kind of graduated scale. there's a schedule, kind of like a marginal tax income, income tax schedule, kind of like that. But there's some kind of schedule that we'd all have to reference and then multiply that by the revenue. There's a note here that this does rely on carrier revenue as reported to DCBS. We have that data. DCBS has that data. So carrier revenue is really well known. Provider revenue is a little different. So provider revenue, we'd have to use the cost growth target data template. And it's almost like a proxy for actual revenue, because remember, the data that comes in on the cost growth target, that shows not just that provider's revenue, but other dollars that were spent for those attributed patients. So we'd have to kind of figure out and dial in exactly how to refine just that entity's revenue. The plus side of this is it includes an upper bound in the penalty schedule. So there's kind of a max penalty amount, if you will. The downside is this is a little more complicated. There's something else to reference. And what I mentioned before, that provider revenue is really kind of a proxy, whereas for the carriers, it's an actual revenue. We know the actual dollar amount. So that's the percent of revenue option number 2. Let's go to door number 3. Next slide. Option number 3 is per member per month. So it would be calculated by the number of member months times some adjuster, kind of like another version of a schedule, times $1 just to monetize it. So think of it like a flat rate penalty per member per month, adjusted up or down based on the level of the target. So again, if the entity is only 1 percentage point above the target with statistical significance without a justifiable reason, maybe it's 0.25% of $1, so 25 cents or something, multiplied by the number of member months you have. The nice thing about this is it's really predictable. So entities would know, even kind of before going in, half of the calculation, because they know how many member months they have. Obviously, how far over the target is a really critical point of the calculation, so they need that. But it's relatively simple, predictable based on number of members attributed. The downside is it's a little complicated because you do have this adjuster. You still have this other schedule, so it's a little wonky and technical. Also, it does not consider high per member per month dollar amounts. So if one entity is over the cost growth target by X%, and they just have really high PMPMs, yet another entity, even within the same line of business, if they're over the same amount, over the target by the same amount, but they have a really significantly less PMPM, they would actually face the same penalty, yet they're actually they're spending different amounts or receiving different amounts if they're a carrier or a provider. So that's one downside to it. So this is the per member per month penalty calculation. Let's go to the next one. And I want to talk about kind of the backstop policies that we could impose here. So we could do some built-in mechanisms to ensure that the penalty will not threaten solvency or any financial stability of the entity. For example, so for payers, we could impose some kind of final step in the calculation to say the penalty shall not exceed X% of reported profit margin as reported to DCBS. So even if the penalty calculated is just this massive dollar amount, well, that gets compared to, okay, X%, whatever that percentage is, of profit margin. And that's really the ultimate kind of max of that penalty can be for carriers. For provider organizations, we could do something similar, such that the penalty shall not exceed X% of reported total spending for primary care as reported in the cost growth target data template. And the reason why we're focusing on primary care is because that's most likely the actual dollars that are going to that accountable entity, as opposed to inpatient spending or kind of other spending that, sure, they were maybe kind of responsible for in the sense that their attributed patients accessed, but those dollars didn't actually come into that primary care facility, right? They went to the hospital down the street. So in a way to try to kind of narrow in revenue for the providers, we could look at just the primary care spend that come in on the cost growth target data templates. So those are a couple backstops that we could impose. Let's go to the next slide. And I want to breeze through this one. So oh yeah, Lisa, go ahead.
Zachary, do you mind if we divide these in half and have a conversation about this and then move to the next one?
That sounds great. That sounds great. And I'll just tee up what this next phase will be. It'll be kind of where penalties go and how we can build in and rule kind of where those dollars have to be spent. But let's pause on that and let's go back to the methodologies. Take it away, Felicia.
I have two questions about the methodology. So in option, I think the first option around the
Overage,
average, the overage. So would you take the average of the 3 years that they were out of step, or the mean for, because a entity has to be off the cost growth target for 3 years. So do you just take a year? Do you take the average? Do you take the mean? Like, what do you do there?
To be determined. I think there's a lot of kind of flexibility there. Now we'll obviously need to land and like put it in rule what the true kind of path and procedure will be. It could be an average. It could be a median. I suppose it could even be kind of the addition of all three. That'd be a much larger penalty. So what I want to focus on now is kind of how functionally we're going to calculate things. Like what are the key priorities we should look at, and what are kind of the data elements we should look at when we're calculating a penalty. And then kind of the secondary conversation is, okay, well then what are the other components of the ultimate calculation? And is it the mean, is it the median, that kind of stuff.
Got it. And then my other question is, I feel like on this solvency slide that you put up, I feel like there are methods to determine solvency right now. Like, we shouldn't reinvent the wheel on how are we determining solvency? I mean, Andrew has his hand up. He determines solvency every day. He's like the decider on that. So I feel like bonding agencies are often the decider on provider solvency for large providers and other things. So I actually feel uncomfortable with reinventing a method in this method to determine solvency. We should just take this other stuff that people do.
Thanks for that. Yeah, great point. Gerardi, can we go back a slide to the insuring penalties and not threaten solvency, just to hover on that one? Thank you. And yeah, Andrew, please.
Thank you. And this is the one I wanted to talk about as well, right? So solvency is extremely important to us as the insurer regulator. And ultimately, I mean, it's important for a lot of reasons. It's a consumer protection perspective as well. So it's very important. The reported profit margin it's probably not, it's maybe too simple or not simple enough. There are, as we said, there's other metrics that we use, risk-based capital metrics that are very complicated, take a lot of things into account, and have certain thresholds where we looked at for companies to be well over before we get worried and then take action. So it could be as simple as one of those references or something else, but that's definitely an area where we're going to want to get our financial solvency experts involved and help. Ideally, Felicia, I agree with you. We can probably just pick one of the many metrics that we already use as a reference point, not to exceed.
And I think I want to just jump in with a quick point that we should have clarified, and sorry, Andrew, because it makes it look like we're not coordinated when we really are. We have been talking to DCBS, and what we've talked about is in the process of determining, there is a final check with DCBS where they look at their data, we look at our data, and then we determine that there's not a threat to solvency. So that would be very coordinated using all of the metrics available. It's not just I totally hear you, Felicia, on reinventing, but I wanted to be clear that we are talking to DCBS about this and planning this together.
Excellent. Let's hear from Melissa, please.
I think there's a lot still, in the details to be worked out. One of the things when we look at per member per month, or that kind of, there's not, from a provider standpoint, there's not clarity on attribution and not standards around that, or even if it's adjusted. And so I think that is a little bit, when we look at those options in particular, that's a little bit challenging because there just isn't that level of detail to understand. And and I don't know that we're ever going to get there. So there's that piece. And then I just wonder are we looking, or have there been conversations within this already around based on market or based on line of business, because it's kind of both and so, it kind of maybe aligns with the question that happened before. If it's over 3 years, which year, all years, if it's just one line of business versus, that's causing an organization not to meet the target. So I think there's a lot of questions around that, but maybe some opportunity to focus a bit more specifically in some of those areas.
And I'm going to jump in real quick because I should have said this in my slides. When we're talking about PIPs and financial penalties, they apply, we measure at the market level. So for an organization, if you're over for Medicaid, we'd be having this conversation about Medicaid. If you're over for commercial, we'd be having it for commercial. If you're over for both, we have it for both. And so for PIPs, we've talked about there could be one single PIP for multiple lines of business if the cost drivers are the same and if the organization manages both lines of business the same. Some folks that's true for, some others it's not. They're really separate teams, really separate departments, agencies, offices, and maybe they would want to submit separate PIPs just because of internal structures, and we want to maintain that flexibility. But all of this is at the market level.
Thanks.
Great. Yeah, great points. Jessica.
Thank you. So I know this is a really complex conversation and what should the penalties be? It's really interesting for me to hear this as somebody who's kind of been in the side of healthcare for a long time. For our fully insured products, our premiums that we are charging need to be approved before they go to market. And there's a lot of review that goes into them. So I think it's interesting that there could also be a penalty like this that we're talking about. And a lot of the payers, especially, some of the regional payers, don't have huge profit margins. So that's the money that groups have to invest in some of these programs. So I think we also want to make sure that these penalties aren't so big that they're compounding and that they are kind of holding the hands of people who want to do more. This would be where they would get some of their money if there is indeed a profit. So I think we need to be really careful about what we do here and how big we go. And obviously I'm talking from the payer side, it's where I sit right now. But there's a lot of oversight that goes into the premiums we charge, what is okay. Rebates are already there if we charge too much and it goes over certain, dollar amounts. Generally at 85% of the premiums we bring in. So I think we need to be really careful and thoughtful how we do this, that we're not compounding problems. We're not overly taxing, certain players and others that it might be easier to pay penalties. So I just think we need to be really thoughtful. I realize that we do need to talk about penalties, but I think we need to be really thoughtful about those unintended consequences.
Thanks for that. Yep, great points. These are great. Well,
can I do a?
Yeah, go ahead.
So before we move on to the second piece, I'd like to just do a quick temperature check on the three options that Zachary presented. So can we go back to the slide with the three options? I can't remember. I think it's slide 62.
61.
61. Slide 61.
There we go.
Okay. So knowing that we don't have all of the information and the detail, the devil is in the details, I'm still going to do a temperature check. And so if people could, I think, do their some sort of reaction. And Jessica, I'll warn you right now, Jessica, your hand's up. Oh, Peter, do you have a question about this temperature check?
Yeah, just real quick. Since you're going to ask that question, one of the questions I had, Zachary, as you were going through it, the overage does not have a cap on it, and the percentage of revenue does. Is there a reason you can't put a percentage or a cap on number one there, or you just had chosen not to?
No, that's a good point. You could. It could be kind of just like a fail stop that. No matter what, the penalty calculation can't be greater than X dollars or something. We'd want to somehow scale that up because we have very different sizes of entities doing very different amounts of business. Some 10,000 lives, some hundreds of thousands of lives. So we'd have to kind of be able to scale it. But I think that's a great point that we could add on. Yep.
Okay, before we talk, I think that there's a changes to these that I think I'd like to talk about because I I'm not sure. I'm into the cap if we have a solvency question, so a solvency standard, but I think I just right now want to get a temperature check of like, people are like, I feel better. And by the way, none of this is not carved in stone. So I'm just trying to get a like, what do people feel good about so that the staff have a direction to head in? And also good might be a different word. What do people feel the least uncomfortable with? How about that? That's the temperature check we're going to do. Of option 1, option 2, or option 3, what do people feel the least uncomfortable with? So we're going to do this by a little reactions button, your smiley face plus. So who feels the least uncomfortable with option number 1? Okay. Who feels the okay, I'll give people a minute to find their reaction buttons. Or you can put it in the chat too. That's the other option. Okay, so I'm seeing Carrie and Nick and Katie and Mary Beth feeling the least uncomfortable with option number 1. Who feels the least uncomfortable with option number 2? Carrie feels good about option 2 too. Oh, Jim is an option number 1. All right.
Sorry, can I just pause to check? That was nobody for option 2, right?
No, I think Carrie felt comfortable with option 2 too. The least uncomfortable with option 2 too.
I think Karis's comment in the chat was about Jessica's comment, not about one of the options, but Karis, can you confirm?
I saw Karis raise her
hand. Manual hand. Okay, sorry, I missed that.
I'm putting my comments right now.
All right. Least uncomfortable with option number 3. I see no one weighing in on option number 3. Is that fair to say? Melissa, do you just feel uncomfortable generally?
You know, just being so black and white on things, you know, I know there's so much in the details, but I think the solvency discussion is super important. You know, what we don't want to end up doing is limiting growth or access in our communities, you know, and there are just so many things right now that are driving up costs in a time that we would have never predicted that things look like they do, you know, 3 years ago. And I think that's the sensitivity at the moment that I walk into some of this. And so that's, yeah.
I think I'm
Jessica?
in the same place Melissa. Yeah, I think I'm in the same place that Melissa's at. I think you need a little more time internally to weigh all these and review them all, and we're actively doing that. But could use a little more time and understand some of the answers to the questions we posed today.
Sure. I think here's the challenge that I'm just going to lay out right now. I don't want to send the staff down a wild goose chase of spending a lot of time developing out option number 3 when nobody here feels great about it. So what I would say is really we're thinking about options 1 and 2, and then hammering out the solvency question more is kind of my summary of where I would say the staff at OHA should spend the vast majority of their time. And then if we go down that path and we all decide at the end of that, no, just kidding, we want to go back to option 3, then let's revisit that at a future place after we've answered the questions to 1 and 2. Does that sound fair to people?
So
yeah, I just maybe have a
Melissa?
quick, I just have a quick question. Even on that % of revenue, and I heard net operating revenue, is that net operating income? Kind of I mean, even that is a question for me, given, where a lot, again, from a delivery system lens, where a lot of delivery systems and hospitals are, we're talking about, potentially. So even like language is important, I think, is when we think about revenue, is that kind of pieces of that too. So there's just
Yep.
more detail.
That's completely fair. And just as a reminder, we wouldn't be pulling in hospital-specific financial information into these calculations because everything is predicated on the cost growth target templates, which is the attribution method.
Yeah. And at the end of the day, to think about putting penalties in marketplaces where you have got, again, who knows what 3 years from this looks like, but I think those are just a lot of the questions that need more work.
So I think there's a ton of questions that need more work. And I think everybody agrees on that. I feel like the staff should spend their time on answering and getting some more specifics on 1 and 2. Does that seem fair? Okay, great.
Nodding.
So the staff are going to spend their time getting answers and digging in on 1 and 2. And that way we can kind of move forward and answer those detailed questions. Now I feel like we're on to the second. I'm not sure. I don't think we should get to the second part of this today, and we should actually kick that to another meeting because I think we're going, sorry, Zachary, I think we're going to go down a very big rabbit hole on this too, where we're going to need a lot more specific answers to the questions. So I'm going to take my co-chair privilege and skip that. Peter?
I appreciate your co-chair privileges and I agree with them. Zachary, as you go through this process, I think it's just really important for your group to think about and be very specific about what the intent of those penalties are. Is it to call out? Is it to change behavior? Is it to create a solvency issue? Is it to take an organization that is experiencing high costs and loss of profitability and then put a burden on them in the marketplace that impacts their ability to create a competitive product and lower costs? So I think it's just really important as you set what the impact is, that we're using that impact to drive changes in behavior, not change the marketplace.
And so, Sarah, I believe when these were established by the previous board, there was sort of a set of values around the accountability. Can we bring those back up and do a reminder when we get into the details next time around on this?
Yeah, and we are just over time. So can I jump in with my non-privileges and propose next steps? Because I want to be careful.
I was about to move us to next steps. That's great.
Cool. Because I want to be careful about timing, because you've both mentioned a couple times, coming back and answering questions. And I want to say that I don't think we were necessarily planning on coming back in September and having another give us direction. I think in September, we want to be starting rulemaking, and we're moving this conversation to the Rules Advisory Committee. So I think if there are questions, we can provide some follow-up over email. I think if there's additional feedback you all have about the slides, about the materials on the slides, we really welcome that over email. There's some prompt questions that Zachary had that we didn't get to. If we need to revisit the rulemaking timeline because the committee wants to spend more time weighing in on this, then I think we need to have that conversation with the co-chairs and think about the September agenda. Does that sound okay? This is the downside of not meeting every month, which I'm really kind of having second thoughts about this year as we go. So I think I'll connect with Felisa and Peter, and we'll talk about what comes back when, and if this potentially results in a change to the rulemaking timeline. But I would really ask all committee members, if you have questions or comments about anything on the slides, to please send that over email in the next couple of weeks so that we can continue iterating. Okay, sorry, back to you, Felisa, Peter, to wrap us up.
I just want to confirm that we didn't have any public comment that we need to speak about before we close.
No, we don't have any public comment
Great.
signed up today. Next steps is on your last slide here. Not necessarily last slide, but So we're just going to wrap up for today. Sorry for going a little bit over. That we have the 2023 public hearing part 2, September 14th. So people should put that on their calendar at 9 a.m. And that we have the advisory committee September 20th at 9 a.m. I think Sarah will get back to us all over email about how we're going to handle the next steps on this component around rulemaking. With that, I'm going to, I don't know, what am I supposed to say? Like, I'm going to close the committee? Are we closing the committee, Sarah?
We're adjourned. Yeah.
I'm adjourning the committee. Bye. Thank you all for coming over the summer, joining from your vacations. Jessica, it's so great to have you on board. We have a lot of work coming up.
Thanks all. Take care.